It's a pleasure to be here. So I'm going to talk about long-term outcomes in survivors of hereditary childhood cancer. And hopefully over the next 25 minutes or so, we'll chat a little bit about long-term health and psychosocial problems faced by childhood cancer survivors, explore specific challenges faced by survivors of hereditary cancers, and then talk a little bit about the challenges we face when trying to care for childhood cancer survivors, particularly once they transition to adulthood. So maybe just for some context, and I'm talking broadly here, obviously not just about hereditary cancers, but childhood cancer in general. One of the, I think, most remarkable advances in medicine over the past 4 or 5 decades has been the improvement in survival of childhood cancer. So this is a slide from the Children's Cancer Research Fund showing that back in the 1960s, if you were a child with acute lymphoblastic leukemia, which is the most common cancer we see, it's about a quarter of pediatric cancers, you had about a 4% chance of surviving. Today, that survival is well above 90%. And in fact, if you look at this data, which breaks it down by different malignancies, you can see that for the majority of childhood cancers, survival has improved drastically. And for most cancers now, it's above 70 to 80%. Overall childhood cancer survival is in the low 80s. Obviously, there are a subset of patients for whom we continue to struggle, be it patients with metastatic or advanced disease. But the truth of the matter is that there has really been a paradigm shift in how we think about childhood cancer from in the 1960s, when it was really an idea of cure at any cost, to really a focus on the quality of the cure. So not just can we make kids survivors, but how are they going to be as survivors in terms of their physical and mental health. So I'm going to start off by chatting a little bit about the general long-term health and psychosocial problems faced by childhood cancer survivors. And when we think about this, in the adult world, when you talk to adults or think about adult oncology, it's often cancer recurrence that sort of looms large, for years or sometimes in some cancers, even decades after the initial cancer. But in pediatric oncology, we do reach a point where we can say to a family, your child is cured. Their initial malignancy is not coming back. And really the focus in survivors of childhood cancers as they move away from that initial diagnosis is on what we call late effects of therapy. So these are the impacts that either the cancer or the underlying treatment has on long-term health. And obviously new cancers is probably the one we worry about the most. It certainly is the highest cause of late morbidity and mortality in our survivor population. This is often due to therapy, but obviously genetic predisposition plays a role, and often there's an interaction between, for example, radiation and some underlying predisposition. We think a lot about chronic physical health conditions, cardiac, renal, pulmonary, pretty much every organ system can be impacted by the chemotherapy and radiation we use. There is, as I'll show you in a while, a risk for premature mortality. We're learning more and more about the mental health impacts of having had cancer as a child, quality of life, and I'll talk briefly in a little while about the concept of financial toxicity. But for the purposes of this slide, just to say these are what we lump into a group of things we call late effects. And obviously the causes of late effects are fairly broad. The tumor itself, if you think about a child who has a sarcoma that destroys bone, or a brain tumor that destroys healthy brain, that can lead to late effects. Clearly the treatment we use, radiation is the number one culprit, but chemotherapy and surgery can do it too. Some children have acute events in therapy, for example, a stroke, that can lead to lifelong problems. Increasingly, we're learning about the genetic factors that either predispose to late effects, or in some cases protect against late effects. We know a fair bit about host factors such as sex and race, ethnicity. The challenge for people like me who really care for these kids once they finish their cancer therapy is that you pass the point where you can make changes in how you treat them. And probably one of the main areas we think about these days is, can health behaviors and lifestyle change the natural history of these late effects? Tobacco use, diet, exercise, sun, etc. A growing area in the survivorship world is that this idea that the normal sort of processes of aging interact with the damage caused by the cancer and its therapy, and so that we often see much of what we'd see in older adults far earlier in survivors of childhood cancer. So diseases that don't usually occur till your 60s and 70s occurring in 30 and 40-year-olds. So just to give you a sense of sort of the impact and the size of the issue, this is some data from a large North American study called the Childhood Cancer Survivor Study. It's a cohort of over 20,000 childhood cancer survivors in the US and Canada that we've been following for decades now, actually. And you can see in the left panel, I'm not sure if I can use my arrow, I can. This is the risk of developing a severe or life-threatening chronic health condition or dying. And you can see that the x-axis starts at 5 years because that's often a place that people use as sort of a starting point for survivorship. So this doesn't count people who died during their initial cancer therapy. They start from scratch at 5 years. And you can see that by about age 50, about half of these survivors have developed a severe or life-threatening condition or died. And this is significantly more than in a comparable sibling population. And it's not just one chronic health condition, it's often 2 or 3 or 4. So they're at risk for severe conditions and often multiple conditions. One of the challenges that we have in caring for these survivors is that often at the time they finish their cancer therapy, and sometimes for years afterwards, they're absolutely fine. So they have cancer, they go through the challenges of that, and they then become what appears to be healthy survivors, often leaving the pediatric world. And it's only when they reach adulthood that some of these chronic conditions start to appear. So you can see, for example, that a survivor who at age 45 has no serious health conditions has about a 20% chance of developing a severe or life-threatening event or actually dying within the next 10 years. And just to contrast that with siblings, they've got about a 7% chance. So you've got almost a threefold chance. And the problem is that over these years, 20, 30, 40, often these survivors completely withdraw from medical care. And so you're not actually surveilling them for these late effects of therapy that might suddenly manifest and cause problems. We also know that their risk of late death is elevated. So this compares, again, starting at 5 years, survivors to the general US population. You can see that the risk of death in an age and sex matched population, and realizing these are fairly young folks, given that these are all childhood cancer survivors or match controls, is really small. But you can see that in those that have survived cancer and lived to 5 years, there's about a 20% or so risk of death within the next 25 years. And as you can imagine, early on, that's recurrence. But as I said before, the risk of recurrence does disappear after a while. New cancers are the leading cause of non-recurrence related death, and then heart disease and lung disease fill out the next 2 slots. Interestingly, external causes, suicide, homicide, accidents are not any different in survivors than they are in the general population, although there is some evidence to suggest that depression, anxiety, and even suicidality might be more common in some survivors. Obviously, as I pointed out earlier, subsequent malignant neoplasms or subsequent neoplasms in general have a really big impact. So the 30-year cumulative incidence of developing another new cancer, so this is not recurrence of the primary cancer, approaches 10%. It's about a 7% risk of developing a non-melanoma skin cancer, and some fairly interesting evidence that suggests that those survivors who develop skin cancer have then a quite high risk of subsequently developing a more invasive malignancy, often related to radiation. As I said before, it's the leading cause of death once you get past about 20 years from your childhood cancer. But if you think about it, if you're 4 when you have your leukemia, we're talking about a bunch of 20-year-olds in which new malignancies are the leading cause of death. The SIR is about 9, and their standardized mortality ratio from malignancies is 15-fold. And obviously, this is in cancer survivors in general. In patients with hereditary cancer predisposition syndromes, the risk for new cancers is obviously much higher. We've done some work in Toronto looking at mental health. We essentially matched about 4,000 survivors of childhood cancer, and we can do this because of the single payer health system we have in the province. We can actually track all the cancer survivors in the province and link them to their healthcare use. And we showed they have about a 34% higher risk of seeking mental health support from a family doctor or psychiatrist, and concerningly, about a 13% higher risk of either landing up in an emergency room or actually being hospitalized with a psychiatric diagnosis when compared to age and sex match controls. So clearly the long-term impact of having cancer goes way beyond just the physical. And as I'll allude to in a little while, in patients with underlying hereditary cancer syndromes, the mental health impact can be far greater because of that sort of looming sense of risk of new cancer. And then this idea of financial hardship. So, there's a lot of evidence in adults, particularly in the US, where not everyone has insurance, but also in Canada and other countries with government-paid healthcare systems, that having cancer has an impact on finances. And increasingly, we're seeing that in children with cancer and adults who've survived childhood cancer, there are similar risks. First of all, their families often have to make financial sacrifices at the time that their kid is undergoing cancer therapy. And then as these survivors age, the impact of their childhood cancer experience or the late effects or their need for extra health also impact. So we generally divide these things up into sort of three domains. So material hardship is higher out-of-pocket medical costs, inability to pay for medical care, which is obviously particularly problematic if you don't have insurance. And as you can imagine, a real challenge for a lot of survivors in getting insurance of the history of childhood cancer, debt, housing and food insecurity, and then for many survivors, inability to engage in productive work, particularly if they've got significant either physical or neurocognitive impacts of their cancer. And in the US and elsewhere, a concept called job lock, where people are locked in jobs, perhaps not the job they'd like to be in, or avoid moving to new opportunities because of fear of losing insurance. We know that this leads to stress and distress about their financial situation, what's called psychological hardship. And then this whole idea of changing your behavior. So for example, not adhering to medications due to costs, skipping them or taking less, or delaying or foregoing medical care due to costs. So this is an area pretty nascent in terms of research, but one that we all need to be thinking about as our pediatric survivors transition to adulthood. So what are the specific considerations of hereditary cancers? Well, obviously, screening for new malignancies. And this needs to be blended with screening for late effects of prior cancer therapy. And then in some cases, that interaction between the late effects of the cancer they had and some underlying genetic phenotype. So for example, if you had a WT1 mutation that increased your risk of developing a renal tumor, but you also had underlying renal dysfunction, that combination obviously would put your long-term risks of running into renal difficulties much higher. So we often need to think of those interactions. There are, if you think about it, sort of issues related both to the therapy of the cancers related to these different syndromes. So for example, if you think of VHL, RCC or multiple benign tumors can often lead to surgical sequelae, depending on what surgeries are done, single kidney or renal function issues if you need to remove a kidney, particularly if it occurs during childhood. These patients don't often get chemotherapy or radiation, but if they do, then those can have long-term impacts. Amongst our patients who develop Wilms tumor because of underlying Beckwith-Wiedemann syndrome, the loss of their kidney can often lead to concerns about renal function. We often use anthracycline chemotherapy for Wilms tumor, and that's been associated with cardiomyopathy. And in those patients who need radiation, this can impact growth, can lead to a risk for scoliosis and an increased risk for subsequent malignancies. And then in syndromes like Li-Fraumeni, where obviously there's a risk not just for one, but for multiple cancers, the late effects are very much related to what the underlying cancer was and how it was treated. So in leukemia, we use anthracyclines, which can cause cardiac dysfunction. We know that cranial radiation and methotrexate, two approaches to treating CNS disease, can lead to neurocognitive dysfunction, and steroid use and methotrexate can impact bone density. If they get brain tumors, obviously there can be significant impacts on neurocognitive and neuroendocrine function and the risk for new cancers in the radiation field. Sarcomas are related to limb and joint problems, cardiac disease, if they get radiation, again, subsequent malignancies, and in patients treated for ACC, adrenal insufficiency is obviously an issue. So I think the idea of this is not to even try and be exhaustive, but really just to show that you need to be thoughtful about not just the underlying syndrome, but which cancers they developed, how they were treated in order to come up with some sense of what long-term follow-up they'll need. In addition to thinking about the sequelae of their prior cancer and realizing that sometimes, there's patients who are known to have an underlying predisposition syndrome but haven't yet developed a cancer, clearly there are screening guidelines to look for future cancers related to the syndrome. In general, we, at least at SickKids, collaborate with our cancer genetics group in terms of many of these kids sharing those screening and healthcare burdens. So, for example, in the Li-Fraumeni population, we will see them in our cancer survivor clinic to discuss the late effects of the therapy they've had, and the cancer genetics clinic will continue to follow them for their future risk. Sometimes when the need for screening is not particularly burdensome, say for example those kids with Beckwith-Wiedemann who only need to get ultrasounds till age 8, we'll do that screening in the context of our cancer survivor clinic. But one needs to be thoughtful about both screening for new cancers related to the cancer predisposition and the late effects and the coordination of that care. And then, as I'm sure you know far better than I do, there are guidelines for many of these diseases. You know, Anita Villani and the group in Toronto had come up with the Li-Fraumeni syndrome screening guidelines. And here you can see, and it's obviously a combination of both screening for new malignancies and then whatever other features there are of the specific illnesses. And in VHL, there've been sort of multiple iterations of screening guidelines, and these are the proposed surveillance guidelines. And because this is really an area that our cancer genetics clinic runs, you know, I think that the folks in this call will have a far better sense of which of these guidelines they use and when. The key point, though, is that patients who have survived a childhood cancer who have these syndromes need both the screening for the syndrome as well as the screening for their prior cancer therapy. So what is the psychological impact of screening? You know, obviously patients are often motivated by their will to stay alive when confronted with a high cancer risk, but this can have both positive and negative psychological responses. So the positive is, you know, it can be comforting and reassuring to know that you're getting screened. The negative is that you can often have anxiety and fear and fatigue around multiple screenings. And as you can imagine, in those patients who are already being screened for late effects and cancers related to the prior therapy, who also need to be screened for future cancers, the psychological impact can be quite significant. And then there's often logistical barriers. So, you know, in the guidelines for childhood cancer survivors who don't have an underlying cancer predisposition from a genetic standpoint, but perhaps have an elevated risk, say for breast cancer because they've had chest radiation, or colorectal cancer because they've had abdominal pelvic radiation, well, that leads to recommendations, for example, for mammography to start at age 28 and not age 40 or 50 as in the general population. And so the recommendation to get annual mammography and MRIs often runs into barriers, either because insurance companies don't see or understand the value, or sometimes because radiologists don't. So, you know, even in Ontario, Canada, where there is no patient cost associated with these tests, if one of our patients living, you know, out of one of the big centers is referred, say, for a breast MRI, often the radiologist will turn that down, saying this is not indicated. And so educating the broader community about the guidelines is obviously important. And I'm going to get into guidelines in a moment. And then, as I said before, the cancer therapy late effects may be compounded by the non-cancer elements of the disease. So caring for survivors of childhood cancer. This is clearly, as survival has increased, become a major focus, both from a clinical standpoint. So these are a couple of publications from the Institute of Medicine, now a couple of decades old, that sort of laid out that we need standards for systems of comprehensive multidisciplinary follow-up care, linking specialty and primary care providers for survivors of childhood cancer. And then there are also focuses on research priorities. And in fact, around the world, there are a range of long-term follow-up guidelines that have been published that guide the care of survivors of childhood cancer. In North America, we use the long-term follow-up guidelines published by the Children's Oncology Group. But the UK has guidelines, Scotland has guidelines, and over the last while, there's actually now an international guideline harmonization group that has published a variety of consensus guidelines that have been adopted internationally. And this just gives you a sense of sort of the breadth of the different groups that are part of this guideline harmonization group. And to give you an example, and this is from the guideline harmonization group, these are the guidelines for who needs breast cancer surveillance. And really it's based on radiation dose exposure. And they use this traffic light, you know, green, highly recommended, yellow is reasonable, and then red is not recommended or does not have much evidence to support it. So the question then is, we have guidelines, but do kids actually get the care that we know they need? So we've done some research again through the Childhood Cancer Survivor Study. This is a fairly old study, but we've repeated elements of this more recently, and the data unfortunately hasn't changed. But we looked at about 8,000 adults who'd had cancer as kids in North America, and we looked at what proportion of the last 2 years has had no medical care. It's a reasonably small part of the pie. General care, meaning they had been seen by a physician, but the visits had nothing to do with their prior cancer or screening or advising them about future risks. And then what we called cancer-related care, which was care that took into account or put their current health condition into context of their past cancer. And as you can see, less than a third of survivors were getting care that was linked to what their risks were. And part of the reason for this, and we know this, wherever we ask the question, be it in North America or Europe or elsewhere, is that as survivors age and move further away from their cancer, their risk for developing chronic health conditions, as I showed you earlier, increases, but the likelihood that they are going or remaining in a cancer center, either seeing the original oncologist who treated them or in a specialized survivor program, goes down. And in fact, by 20 to 25 years out in North America, it's probably only 10 to 20% of these adults who are still engaged with the cancer system. The majority are being seen either by their family physicians or not receiving medical care at all. And so obviously there's this divide between risk and where you're being seen. And unfortunately, this has an impact. We looked at this by seeing the adherence of survivors to surveillance guidelines. And we looked at the average risk surveillance guidelines. So these are guidelines for the general population. So for example, in the US at the time of the study, mammography, all women were supposed to start it when they reached age 40, pap smears at age 21. And then we looked at patients had elevated risk. So women who'd had more than 20 gray of radiation to the chest, who need to start mammography in their 20s, survivors who have had more than 30 gray of radiation to the abdomen should start colorectal cancer screening in their 30s and not later on. And then those who had had any radiation therapy where we know the risk for skin cancer is elevated, and really someone should do a head-to-toe skin exam. And what we saw is when we looked at the general population screening guidelines, adherence was reasonably good. 67% were adherent to mammography, 80% to pap smears, and this was actually pretty comparable to the general population. But when we looked at those high-risk patients, it was quite dismal. So only about 12% of those at risk for colorectal cancer were up to date on colonoscopies. Less than half were up to date on mammography, and only about a quarter had had a skin exam in the past several years. And really what this suggests is it's not a lack of motivation. It's really a lack of knowledge among survivors and their physicians. And this is clearly problematic. We've shown this in different ways. For example, we looked at adherence to mammography in patients who were still in a cancer center or had moved to the community and saw significantly different rates of screening uptake in those two groups. And then we sort of reached out to primary care docs, so mostly family doctors, but also general internists, because they do a lot of the primary care in the US, to understand what the barriers might be to caring for these survivors. So we were interested in adults who'd had cancer as kids. And as you can see, only about 50 to maybe 60% of these primary care docs had even seen one childhood cancer survivor in their practice in the last 5 years. And the problem is, if you only have a handful of survivors, a survivor of a brain tumor is fundamentally different to a survivor of, say, leukemia. And so knowing how to look after one does not necessarily translate to looking after the other. And the other part is when you're in a busy primary care practice where you're dealing with common diseases, dementia, diabetes, those sorts of things, you have very little time to focus on those, once in a rare while childhood cancer survivors. And as a consequence, the majority of these folks actually were quite uncomfortable caring for childhood cancer survivors, and very few wanted to care for them independently. What was striking is that they were willing to care for them, but really needed collaboration with the cancer center to sort of help them in terms of guidelines and access to resources, etc. We also looked at knowledge. So we asked some multiple choice questions about their knowledge of the published guidelines. And as you can see, amongst general internists and family doctors, only a minority were aware of the screening guidelines for breast cancer. Many of them knew about thyroid function screening in patients that had neck radiation, but very few knew about the cardiac screening guidelines. And you can see 5% of general internists and only 2% of family docs knew all three guidelines. Interestingly, and somewhat concerningly, only about a third of pediatric oncologists were actually familiar with all the guidelines. But as you can see, there's a clear sort of knowledge gap and comfort gap in family docs caring for childhood cancer survivors in general. And my suspicion is that when you then add in underlying hereditary cancer predisposition, that probably, hugely increases this discomfort. So in the interest of time, I'm going to stop there, but I'm happy to answer some questions, but just some conclusions. First of all, childhood cancer survivors are at risk for physical, psychological, and psychosocial led effects. Patients with inherited cancer predisposition are at elevated risk, obviously, for new cancers, also interaction of the disease phenotype with the late effects they develop from their prior cancer. There are evidence-based guidelines both to guide the care of survivors, but also to guide the care of patients with hereditary cancer predisposition. And we really do need to think about how we make sure survivors have access to both. We know that many survivors don't get evidence-based care, particularly if they're no longer being seen at a cancer center. So we need to think about models that integrate or coordinate care of syndrome-related health issues and late effects of cancer therapy, and figure out ways to do this both within the sort of tertiary care cancer complex environment, but also how to provide this care to survivors in their own communities from their primary care physicians, because we know that despite their risks, many of these survivors, even if given the opportunity, are not going to be willing to come back to the specialized centers for their surveillance care. So thank you for spending part of your Saturday morning with me, and I'm happy to answer any questions.
Thank you, Dr. Nathan. If you have a question, please go ahead and raise your hand, or alternatively, you can also send a message via the chat. I think I saw a raised hand. Jess, please go ahead.
Hi, Dr. Nathan.
Hey, Jess.
I was wondering, specifically for myself, I find that because VHL is such a rare disease, I have always coordinated my own care. I once had a nurse practitioner print off the entire, WebMD version of what doctors look at when they don't know what disease you have.
Mm-hmm.
So she printed off and gave it to me, and she said, you need to make sure that, you're having these scans and these dates and things like that. Have you ever considered self-management of childhood cancer survivor, doing that sort of similar thing with them?
Yes, that's a superb question. So the answer is yes, and I didn't show it in these slides, but at least in the context of their survivorship risks, everyone at the time they graduate from a pediatric program in Ontario gets a survivor care plan and a treatment summary. So it's a binder, but it has in it a 1-page or 2-page, depending, handout that says what their diagnosis was, what specific treatments they got. So, what were your chemotherapies? If dose is important for stratifying risk, what those doses were. And then importantly, a list of the specific screening you need. So you need mammography starting at this age, with this frequency. You need echocardiography with this frequency. We do not yet integrate the screening for the hereditary predisposition. I don't know if any of the cancer genetics clinics are doing that, but certainly the opportunity to sort of amalgamate those two sets of guidelines is one that I think we should be thinking about. The problem, Jess, is that a lot of survivors either don't or can't advocate for themselves. When we think about brain tumor survivors, for example, many of them have neurocognitive issues. The other challenge is that, during childhood, most of our patients, their parents are their advocates. And because of the nature of the healthcare system, we're often forced to transition kids out of our hospital at age 18. And a lot of them are not yet at a sort of maturity level where they're ready to take on their own healthcare responsibility. They're still sort of deferring to their parents. And so I think there's this kind of lost period where they transition out of our care. And if they don't land up in an adult survivor clinic that can do that education, some of them just return to the communities, and that sort of passing the torch from parent to child doesn't happen. So we're doing a lot of work to think about how to do this. We're also about to launch a study in Ontario where we will be sending reminders to childhood cancer survivors and their primary care physicians to get screening. So based on what we know about the treatments they had, and by linking them to their healthcare use, we'll be able to know who hasn't had a mammogram or colonoscopy. And the study is looking at, can we send either text or mail reminders that they can use to both remind them and also to help them advocate. Take them to your family doc and say, hey, here's the thing from Sick Kids or from Ontario Health that says I need a mammogram or I need this test. But empowering survivors to advocate for their own care, I think, is super important. Unfortunately, I don't think it is going to help everyone, but certainly we need to do a job for those who would use those tools.
Thank you. Dr. Van Leeuwaard, please go ahead and ask your question.
Dr. Nathan, thank you for your very interesting talk. So what are your thoughts about the comparability between children with sporadic tumors in comparison with the children with VHL? And do you think there are special needs or attention for the children with an hereditary tumor syndrome?
So, I mean, as I hope I sort of alluded to in my talk, absolutely there are, right? Because you're trying to blend you had this cancer, you got these treatments, these are your long-term risks, with this is your underlying predisposition, you're at risk for these new cancers or for the other manifestations. I think one of the challenges we have right now is that we don't have a unified clinic for most of these illnesses where we deal with both sides of that spectrum. As I said, at Sick Kids, mostly we deal with the late effects in the cancer survivor clinic and then the cancer genetic and predisposition in a parallel clinic. I think the model works. I could see the opportunity to integrate those two models together. I think, as we learn more and more about who underlying predisposition to cancer, and as that population is recognized maybe to be a larger and larger proportion of the patients we follow, we may think more, for example, integrating a cancer genetic counselor into the late effects clinic. We actually modeled that for about a year at Sick Kids and actually found it extremely useful because we were always thinking both backwards and forwards. We just didn't have the resources to do that. And that was more the challenge than anything else. But clearly, patients with hereditary cancer predisposition have needs that are over and above those that have just had a sort of sporadic cancer. Do we do a good job? We could do a better job.
Thank you.